OK，谢谢大家让你。Oh, is there a microphone on? Can hear. 谢谢大家让我跟你今天跟你讲。Thank you, ladies and gentlemen. Thank you to the moderators, to the organizing committee, to Pace Journal, Dr. Ma. I will be talking to you today. My title is, I decided to title Atrial Fibrillation Ablation Without Fluoroscopy. Should it be the standard of care yet? There's a little bit about myself, and here are my disclosures. So I decided to start talking about this in a historical context a little bit. And the first timeline I'm showing you here today is basically an ablation timeline. So going back to, I think, perhaps the start of thinking about arrhythmia ablation is when Professor Mines first described atrial flutter reentry over 100 years ago. And you fast forward to description of atrial fibrillation as a chaotic electrical activation. And then the first instance of intervention for arrhythmias when there was surgical treatment described for WPW. And then understanding some of the mechanisms further with Mark Josephson's seminal work on VT ablation in the surgical field. And then eventually Mel Scheinman and others who developed catheter-based ablation approaches. And then more recently, of course, Michel Hasseguer, who first described pulmonary vein triggers and the concept of pulmonary vein ablation and then isolation. And then I have a big fast forward for the last 30 or so years when we've really spent a lot of effort and time to further refine understanding mechanisms of arrhythmia and then our approaches to treating them interventionally. Now, when you couple that with what's happening with atrial fibrillation, we understand now, of course, that AF is the most prevalent arrhythmia worldwide, and these are figures from the European guidelines published in 2020. And you can see the various figures here showing that the lifetime risk of AF is quite high across the world. It becomes more common as you age. And there's variations depending on what part of the world you're looking at. Now, because we are here in China today, I decided to show some data relevant to the much of the audience today, which is that indeed, similarly in China, AF is the most common sustained arrhythmia in clinical practice. Approximately 4 to 5% of the population over age 75, and similarly increasing in with age. And then these are some of the regional distributions of AF prevalence. And in other relevant way of looking at it too is, of course, ablation procedures have become very common in China. The case volume, as you all know, is increasing significantly over the years. But here's the problem, as I've highlighted in the bottom. Of course, more cases will then eventually mean more operator X-ray exposure and more orthopedic consequences of lead apron use. So before we could even talk about this concept of ablation without fluoroscopy, I would say zero fluoroscopy ablation, mapping techniques, ablation techniques are all derived from the interventional cardiology space. So these are, of course, fluoroscopy-based, but they're not really ideally designed for an intracardiac and non-vascular anatomy that we're treating in the intracardiac and in sometimes epicardial space. And then also, of course, with increasing case volume, you have increased radiation exposure, increasing orthopedic stress. And then in the increasing complexity of our procedures has made these procedures longer in many ways, and then also then further increases the risk. And you may be familiar, of course, then in the radiation safety realm is that there's a concept called ALARA, which stands for as low as reasonably achievable. So that the guiding principle is that if we can figure out a way to safely and effectively perform interventions in medicine with as little radiation as possible, that should be the way we approach these procedures. And that's true for us too. And this slide is really just to illustrate some of the problems. So I show this slide a lot, but this is a patient that was referred to me now many years ago, but this was several years after she had had a very long ablation procedure, 90 minutes of fluoroscopy exposure, and she had a non-healing 5 years later skin lesion that was permanent. And obviously you can imagine the previous operator did not move the X-ray arm at all during the procedure, et cetera. And so that's just a case example. But if you look at data, This is data that estimates the risk of malignancy in a patient exposed to AF ablation, at least modeled for per every 60 minutes of fluoroscopy exposure. The increased risk, both in males and females, of associated malignancies is significant. In addition, as I've alluded to, we as operators can encounter a lot of orthopedic issues wearing lead aprons, and as high as 30% in one study of spine problems, over 60% in another observational study for musculoskeletal problems. And this is anecdotal, but we all know many instances of oddly site-related malignancies among operators, and so these are all significant concerns we have. And then I'll add one more argument, which is that I don't think fluoroscopy is actually that useful for EP, because what we're looking at is really global tissue edges. We're looking at catheters. We're not looking at intracardiac structures. We're not looking at anything when the fluoroscopy system is not activated. So here's what I think is the becoming the solution. So we already have all the tools necessary to achieve zero fluoroscopy. So between a mapping system and intracardiac ultrasound, we can achieve all of this. So how about zero fluoroscopy? Another timeline. So if you look at when ablation was first, catheter-based ablation was first developed, you want to actually go a little bit farther back. ICE was first really described and developed in the 1980s. It's obviously we spent many years refining ICE techniques, and electroanatomic mapping was first described, of course, in 1998. And again, you fast forward, and now in the last 10 to 15 years, there are now a growing number of descriptions of being able to perform many of these procedures with less and less fluoroscopy. And that's in part because of the rapid advancement in both mapping and ICE technology. So what I'm going to do then with that introduction, so to speak, is spend just a very few brief slides, just going, because this is not the purpose of the talk, going over some of the techniques and things you want to look at, but I want to focus on, for most of the rest of the talk, some of the data that we've been able to collect related to all of this. So very briefly, our approach is if you look at the workflow on the right, I'm not going to go over step by step, but if you look at all these steps, they're essentially identical to what most of us would do anyway with a fluoroscopy-based approach. We just replace much of our imaging with ICE or a mapping system. And this is our typical workflow in our lab, so it's very similar to, I think, many labs that are doing ablation of any sort. First step is to obtain vascular access and advance all the catheters under ICE guidance. I'm not going to go over the details, but I can tell you that this is very reliable, and there's in fact data published demonstrating safety and efficacy of ultrasound-based access. I think the most important step in many minds in adopting the skill set is how to perform a transeptal puncture with ICE guidance only. And this is just a quick view of how we do it, where you can manipulate the ICE to be able to visualize, as shown in both the left and the right, the SVC, so you can advance a wire. And then as shown on the bottom left, a sheath over the wire that we can see exactly where it's going. And then this sometimes can be augmented using imaging, like cardo sound, for instance. And then under ICE, you can perform your whole transeptal procedure. And this shows the dragging down and the tenting, which is not running there. And then, of course, the puncture that lets you then cross. And then once you cross, as shown here, then you can use ICE to manipulate everything and mapping system to manipulate everything in the left atrium. This is a paper that we published now in 2020, multi-center study looking at over 700 transeptal puncture procedures performed with 0 complications and 100% success rate, and no increase in procedural time. So I think this is safe, feasible, and efficient as well. Now, once you're in the left atrium and beyond, you can utilize all the different features of ICE and the mapping system. This is just an example of using cardo sound, which many I know in the audience use for structural delineation and such. So where we're at right now, I think there's some very important highlights, but then some also important hurdles that we still have to overcome. The good is that there is rapid increasing adoption across at least the US. There's rapid adoption now that's already underway in China, in Australia, Japan, other regions. And mapping systems are, of course, ubiquitous. So we have all the tools available. Now, the limitation, as many of you may be aware, is in particular in Europe and in some other regions, ICE has very limited availability. So that's a strong limitation. There are others within Europe who are looking at other strategies using transesophageal echo or with a CT-guided approach, et cetera. But hopefully we will be able to make some progress with ICE. And now I ask then, so what's the evidence that this is a safe and effective approach? So I want to highlight two things that are, I think, very illustrative. So on the bottom is if you just do a recent PubMed search. So now there are, in the hundreds of papers that are specifically related to a zero fluoroscopy ablation approach. So this is, and you can see the exponential growth in publications over the last several years. This is the last year here, of course, is this year, so it's not complete yet. And they have almost universally showed safety and efficacy. Of course, very few of these are RCTs, but at least in many single-arm studies, there is favorable outcomes. And then I think very importantly, and this is a segue into some of the work I want to show you for the rest of the presentation, is that with strong evidence, now this is the first time there's been a mapping and ablation system that actually is approved by the US FDA at least to be used in a workflow without fluoroscopy. So I'll show you some of the evidence on how this came about, that we were able to have the opportunity to work with industry to obtain. Actually, I think of the interest of time, I'm going to go very quickly. It looks like we have some topics, but just to say very quickly, once we're in the left atrium, the ablation techniques are the same as everyone else would do. So when we use RF, we will utilize typically a high power short duration approach. We will use index guided ablation. We are more recently adopting using more novel techniques without fluoroscopy, including QDOT for the Biosense system, including cryoablation, which is obviously not so novel, but can be done well without fluoroscopy, as many have published data on that. And now more recently, of course, pulsed field ablation without fluoroscopy. Now, I'm going to spend a couple of minutes talking about how we can then, based on this platform, improve the procedure even further. So how do we gather evidence and validate strategies to further improve our ablation efficiency, or efficacy, safety, and efficiency? So I want to introduce something that we've been working on for the last several years. It's called the Real AF Registry. So this is a concept that we came up with, which is, of course, performing a either industry-sponsored IDE study or performing a large-scale randomized study is expensive, impractical, and very much ad hoc, meaning that it's to answer a specific question. So we thought of this concept of, and there are many, of course, society-sponsored registries and whatnot, but this is a very specific registry that is primarily US-based, but now we have sites in Canada and in Europe and beyond, where we've enlisted sites and operators who are already performing very high volumes of ablation procedures. They perform mostly either zero or very low fluoro approach already, and then we are just tracking outcomes based on a standard approach to ablation, a standard of practice for clinical management, clinical follow-up, including arrhythmia monitoring for long-term clinical outcomes. And so we currently have about nearly 50 centers involved in this study, and we have at this point a little over 7,000 patients enrolled with a goal of about 15,000 patients. And the added feature, just as an aside, and I'm happy to answer questions about this concept, but there's also a process of what's called a learning health network or initiative, where now these operators are also talking to each other and using their best practices to try to improve the whole system's best practices. So it's a very collaborative effort. So I think quite unique. So just an example or an illustration of this. So we designed a process now. Basically every month, each center and each operator will receive basically a report. I'm not going to go into all these details, but it shows their typical ablation patient population, their typical ablation numbers, like their times and the procedure times, the fluoroscopy times, time to first, or frequency of first pass vein isolation, all of those things. And then we look at their also their longer term outcomes, as you show on the upper left here. Boy, this is a little jumpy, but on the upper left you will see here this is 1 year follow-up for these patients in freedom from AF with rigorous monitoring, and you can see the outcomes that generally look quite good. And so what have we been finding with this? So using a high volume center, high operator volume, low fluoroscopy approach to ablation, we see, first of all, this is interesting, the trend over several years now is a continual decrease in ablation time. We see very good clinical success, and I'll show you some of the data there. But we started asking then questions. So what are different centers doing in particular differently that may help to improve outcomes? And so we started off, one of the first things we looked at was, so just a very simple question. So if you're able to achieve first pass vein isolation, what are the determinants of that? And so what we found, for example, is that, primarily use of high power short duration, use of drug challenge, whether those relate to first pass isolation. These are the kinds of questions we were asking. And what we found was that, so one of the things we found for that was this, for example, if you are able to achieve first pass isolation in your pulmonary veins, you are much more likely, as you might imagine, to achieve 1 year freedom from AF. This makes biological sense because we think that the idea is if you have to go back to a certain location and continue to re-ablate, especially with RF, that you're probably already ablating an area that has tissue edema, and you're more likely to have recovery of conduction in that area. So we, at least our long-term 1 year outcomes from freedom from AF go along with that finding. We also found that when you do achieve first pass isolation versus not, as you can see in the columns on the left and the right, that you're much more likely to have a shorter procedure time, less RF delivered, less PV ablation time overall, less time to isolate the veins, of course. In addition, what are some of the other things that we can see? So now we start looking at questions of how do you achieve first pass isolation better. So what we have tracked in our data set are how do we approach the ablation to have things like better catheter stability and all that. So this led to one other study that I want to just highlight a little bit here. So we looked at a concept or an approach that we called high frequency, low tidal volume ventilation. I know in many centers here in China and then elsewhere in the world, patients are ablated using conscious sedation, but at least in the United States, nearly 100% of patients, at least with RF ablation, have their procedures performed with general anesthetic. So you may be familiar with the data or the literature that jet ventilation provides much more catheter stability because you remove respiratory excursion from cardiac catheter interface movement and interaction. Similarly, there's also data that shows that performing intermittent breath holds during ventilation, so you stop respiration for a few seconds while you're delivering RF, that also increases catheter stability. And I didn't mention in this slide, but there's also literature looking at high or short cycle length or high rate pacing in the atrium to increase cardiac contraction time or frequency so that you have less time for longer filling times. And that all those things help to improve stability. So what we thought was then you can take a standard ventilation machine and then reduce the tidal volume as shown here compared to standard ventilation, and then perhaps achieve similar or at least comparable results. And that's shown here too. So when we do is, as you know, you can look at the respiratory gating on a mapping system, and you can see that when you turn on the high frequency ventilation here, the excursion goes down significantly. And here's the results. So what we found is that when you do that, you have statistically significant, reduced procedure times, reduced RF times, reduced PV RF times, and increased first pass isolation. And perhaps most importantly, we saw is that 1 year follow-up, freedom from AF is significantly improved as well. So again, going along and building on that idea that first pass isolation predicts better long-term outcomes, and how do you improve that overall? So getting to the summary, how does all this fit into what I set out to talk about with is a zero fluoroscopy ablation approach. Well, I think that's part of the approach, and as I've shown here, there are things that you can do with the workflow, including rapid pacing, high frequency, low tidal volume ventilation under general anesthetic, as well as ablation tools like high power short duration, other ablation tools, cryo, PFA, index guided ablation, and you overlay a zero fluoroscopy or low fluoroscopy approach to optimize your workflow, and that's what we at least advocate for. So I think our next steps would be then to try to disseminate this knowledge further, of course. We hope that this will, because of the growing literature and data supporting the benefit of this, I think that it will be eventually in the guidelines that will support use of this. And then as a result, incorporate it into your standardized optimal AF ablation workflow. So to summarize, fluoroscopy-based EP procedures, they have been derived from vascular procedures, so they're really not ideal. It's not an ideal technique for imaging in EP procedures. Technology advances for ICE and mapping have really enabled us to get to this point where we eliminate fluoroscopy. And zero fluoroablation can and probably should be part of a standard ablation workflow, because we have, I think, and others have demonstrated that it's has good efficacy. It has certainly good safety, and it does not diminish efficiency. And in fact, we've studied other ways to further improve efficiency with our ablations. So I'd like to end by just acknowledging our local group at Brigham and Women's Hospital. This is our registry and our collaborators in the registry. And I'd like to thank you.